A 65-year-old woman comes to the physician because of recurrent headaches. They are accompanied by transient visual impairment. Heart rate is 90 beats per minute and blood pressure is 140/90. Laboratory studies show elevated ESR. Which of the following is most likely to be found on a biopsy of an appropriate artery? Choice A, concentric smooth muscle proliferation. Choice B, transmural fibrous thickening. Choice C, fibrinoid necrosis. Choice D, granulomatous inflammation. Or choice E, necrosis with neutrophilic infiltration. I'll wait 5 seconds and answer the question. So for this question, I said appropriate artery instead of giving you a specific artery, because if I just told you which artery it was, it would make it a lot more obvious. But even without that, you should be able to recognize that this is giant cell arteritis, which mainly affects the carotid and temporal arteries. You have a patient that's over 50 years old. She has a headache, visual impairment, and the elevated ESR. These are all suggestive of giant cell arteritis. Now, in real life, you would not get the ESR right, because you should be able to make the clinical diagnosis of giant cell arteritis, or because you suspect giant cell arteritis enough, you would immediately give IV corticosteroids to avoid permanent vision loss while you wait for biopsy or ESR to even come back. But anyway, this question is asking about the histology. So for giant cell arteritis, you need to know that, as the name implies, you would have multinucleated giant cells in the vessel walls, and you would have granuloma/granulomatous inflammation. So choice D is the correct answer. Now, granulomas themselves are kind of non-specific, even in the context of just vasculitis, but I'll expand on it in a second as I talk about some of these wrong answer choices. So choice A, concentric smooth muscle proliferation. This is referring to hypertension. Hypertension, if you keep pounding the arteries, you can lead to an onion skinning of arterial walls. So in other words, you can have a concentric growth of smooth muscle. You should be able to recognize this. Choice B, transmural fibrous thickening. This is a little bit non-specific. This can technically refer to hypertension as well, but it's also something we tend to hear with Takayasu arteritis, which is another large vessel vasculitis. Compared to giant cell arteritis, Takayasu arteritis is more found in younger patients, less than 40 years. It's found mainly in Japanese women or Asian women. You can find decreased pulse or BP in the upper extremities. And that's because Takayasu arteritis tends to involve the aorta and the big vessels there, as opposed to the carotids or the temporal arteries like giant cell arteritis does. The age/location tends to be a big giveaway as to whether they want giant cell arteritis or Takayasu arteritis on step exam, because if you look at histology, they're actually pretty similar. You can also have giant cells on Takayasu histology, as a matter of fact, and you can also have granulomas. But transmural fibrous thickening is referring to how over time Takayasu can cause the thickening of the vessel walls, which is actually what leads to a lot of the clinical findings of Takayasu, which are where you have a weakened pulse on the upper extremities because the arteries have become so thick that, blood can't get through. And sometimes you might even get a situation where one arm will have a weaker pulse than the other, and you don't want to get this mixed up with something similar you might find in an aortic dissection, right? In addition, Takayasu arteritis can also have hypertension, because if you have thickening or reduced blood flow to the kidneys, that can activate the ROS. And similar to giant cell arteritis, it also can cause an elevated ESR. Choice C, fibrinoid necrosis. This can be used to refer to various necrotizing vasculitides, such as polyarteritis nodosa. Polyarteritis nodosa, we of course think of the string of pearls sign, and we especially think of it in the renal arteries especially. It can also be found in coronary and mesenteric arteries. I would definitely recommend going to look up the angiogram to polyarteritis nodosa, because it is one of those things you want to be able to recognize on site, and you want to be able to differentiate it from fibromuscular dysplasia. And I guess another random fact that has come up about polyarteritis nodosa before is that there's a hepatitis B association with the disease. Choice E, necrosis with neutrophilic infiltration. Again, this is somewhat non-specific. Neutrophilic infiltration can be found in a lot of things. It can be, of course, found in infection. It can be found in leukocytoclastic vasculitis, which is where you have a bunch of leukocytes being destroyed and they settle along the vessel wall, essentially. It can also be found in small vessel vasculitides, such as granulomatosis with polyangiitis or eosinophilic granulomatosis with polyangiitis, formerly known as Wegener's and Church-Strauss. I wouldn't worry too much about histology for those two. I think it's higher yield to know granulomatosis with polyangiitis is C-ANCA, whereas eosinophilic granulomatosis with polyangiitis is more P-ANCA. And P-ANCA is also found in microscopic polyangiitis. And of course, with granulomatosis with polyangiitis / Wegener's, you want to be thinking there is rapidly progressive glomerulonephritis, a nephritic syndrome, and you will have hemoptysis or a cough or dyspnea alongside some kind of finding in the head, like oral ulcers, nasal septal perforation, sinusitis. Can be any number of things. Whereas eosinophilic granulomatosis with polyangiitis / Church-Strauss, you want to be thinking lung involvement, rapidly progressive glomerulonephritis, alongside some kind of allergic sounding reactions like skin involvement, purpura. If there is no upper respiratory tract involvement, then that would be more microscopic polyangiitis. So I know that was a lot. When we start talking about vasculitis, it can get very complicated. So to get back to a main learning point for this video is giant cell arteritis. You want to be able to identify this very quickly. You know, this whole headache, vision loss, maybe jaw claudication in an elderly woman, especially with elevated ESR and that sort of thing. You want to be very suspicious of giant cell arteritis, and you need to know that you can see multinucleated giant cells and granulomas on a biopsy. And you need to know that when you suspect giant cell arteritis, you need to immediately give IV corticosteroids instead of waiting around for biopsy results or ESR to come back. I hope you found this video helpful. I'll see you in the next one.